Hi everyone, my name is Elena Floyd, and for this presentation on exercise prescription in special populations, I'll be talking about multiple sclerosis, otherwise known as MS. What is MS? MS is an autoimmune disease that affects the brain and spinal cord, also known as our central nervous system. It attacks the protective sheaths on our neurons, also referred to as myelin sheaths. There's a disruption between the brain and the body through communication in this disease, and it decreases the motor and cognitive functions. There's only roughly 200,000 new cases per year in the United States. What are myelin sheaths? Myelin sheaths are protein and fatty insulation around neurons or axons. They're a catalyst to action potentials, and they increase messages from the brain to the body. Here I have an image of a neuron, and you can see this is where the axon is and the myelin sheath surrounding the axon. Why are myelin sheaths so important? They aid impulses movements across the neuron without any leaking. They protect and support action potentials. You'll hear me use the word demyelination a lot, and this is essentially the loss of myelin on these axons. And with multiple sclerosis, demyelination slows or blocks the messages from being transferred along the nerve fiber. MS can also be considered a clinical disability due to this demyelination. And here you can see an image of what a regular axon looks like with myelin sheath, and then what a damaged myelin sheath looks like. Some symptoms of multiple sclerosis are numbness or tingling in limbs, pain in certain areas, loss of balance, inability to move certain body parts, or paralysis, loss of mobility, bladder control problems, fatigue, mental fog, vision problems, and anxiety or depression. Flare-ups of multiple sclerosis are essentially a period of time where there are new symptoms or relapses that develop over days or weeks. The first flare-up is commonly when someone is diagnosed with MS. This is a time period where there's sensory loss, there are balance problems, mobility loss, fatigue, or dizziness. Any flare-ups following that essentially are just worsening of the demyelination. A lot of people become wheelchair dependent in following flare-ups, and there's also a lot of paralysis that can come with the flare-ups. Diagnosis of multiple sclerosis. There's a mixture of clinical evidence and results from things like spinal taps or MRIs. There's a very important criteria to follow while trying to diagnose someone with MS. To begin, you have to be able to prove that there is damage to two separate locations in the central nervous system, and also prove that that damage occurred at two separate times. You also have to run any other tests to rule out any other diseases they could be diagnosed with. Common tools for diagnosis is a medical history and neurological exam, of course an MRI or spinal tap, and there's also the chance of measuring electrical activity in the brain to see if there's a way to diagnose it through that. Treatment of multiple sclerosis. There is no cure for multiple sclerosis, unfortunately. The National Multiple Sclerosis Society says that 150 minutes per week or more of exercise and or physical activity is a great way for those to get better with MS, and symptoms can be minimized or non-existent with physical activity, exercise, physical therapy, occupational therapy, and interferon beta medications, which I will talk about in a few slides. Progression of multiple sclerosis. Every individual has a different progression. It commonly worsens to paralysis or mobility in limbs with time. There are 4 disease courses, sometimes also referred to phenotypes, to consider with MS: clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, or primary progressive MS. We won't dive too deeply into this, but just remember that these are commonly something that is diagnosed before MS, and many people will end up developing MS shortly after developing these diseases. It is important to remember that the progression of MS is undeniable and that it looks different for every single person, and as each flare-up occurs, the symptoms will get worse. The effect of MS on exercise. Physical activity decreases the chance of continuing flare-ups. There is evidence-based research that shows that symptoms and flare-ups decrease with continuous physical activity and exercise. Sedentary behavior is commonly associated with a lot of the secondary complications and spasms, and unfortunately most individuals with MS lead a sedentary lifestyle compared to those who do not have MS. Exercise can be shown to slow down the atrophy and disability, but due to the extreme fatigue many people endure with MS, they tend to leave sedentary lifestyles, which is extremely unfortunate because we know of the amazing benefits that come with exercise. with symptoms of MS. Management and meds. Like I mentioned, exercise has been shown to decrease symptoms and also manage flare-ups with MS. There is a very commonly prescribed medication for MS called interferon beta medications. These are injected directly into the muscles. They help reduce the severity of flare-ups as well as symptoms and spasms that come with it. They can also reduce the frequency of relapses. They decrease inflammation and prevent nerve damage that could potentially cause future relapse. Finally, diving into the case study details, conversation, and goals. Miss Roy is a 55-year-old woman diagnosed with MS in 2008, 14 years ago. She's mobile and currently not wheelchair dependent. She doesn't follow a strict exercise regimen, however, she does get about an hour of physical activity every day gardening in her yard. Miss Roy has mentioned significant mobility deterioration within the past 5 years, and she has been diagnosed with depression and anxiety. Miss Roy wants to decrease her lumbar pain and increase her core strength. She has a goal to lift and carry the bags of soil in her garden without needing any help. And she also wants to spend more time with her grandchildren and not have to worry about falling or her balance issues that she has mentioned. She strongly wants to decrease the debilitating fatigue she is going through. The objective and laboratory data for this case study is that Miss Roy has a height of 170 centimeters, the weight of 59 kilograms. She has a BMI of 20.4, a blood pressure of 125/75. There has been noted some discoloration along her skin, and this has been informed that she does have an ochronosis diagnosis to remember. She has a total cholesterol of 187, triglycerides of 106, HDL cholesterol of 46, an LDL cholesterol of 126, a non-HDL cholesterol of 170, a glucose of 102, and then her resting heart rate was 100 beats per minute. Her max heart rate was calculated to 165, and then her heart rate reserve was 65. Case study pre-exercise testing. Miss Roy has been cleared by her primary care physician as well as her neurologist to continue with exercise. She's filled out all of the clearance paperwork and met all necessary steps to exercise. That is why I've also shown the PARQ to the right of the screen, just showing some of the paperwork that she has completed. Miss Roy will be referred to a counselor to increase self-esteem as well as work on the depression and anxiety that is coming with the multiple sclerosis symptoms. She will also be referred to a dietitian to work on proper nutrition as she will be entering a new state of life with her new exercise prescription, and it's important to meet those needs with her food. Case study initial exercise testing. For her aerobic testing, she will be doing the 6-minute walk test using the rate of perceived exertion, heart rate, and distance to measure everything. This is a cardiorespiratory endurance test that takes less than 10 minutes, so it's a really great option for people that fall under a special population like MS. This is a back and forth consistent walking on a 30-meter walkway with no obstacles in the way for 6 minutes. Her resistance initial exercise test will be an isometric test using a hand grip strength. The test will be 3 different trials, squeezing for 3 to 5 seconds in her right hand. I'll compare the norms and track progress using the kilograms on a hand grip. Finally, her flexibility initial exercise test will be the sit and reach flexibility test using the inches on the box to track her progress. She'll have 3 separate attempts, holding for 2 seconds each time. And then below I've just shown the norms that I've used to measure everything and track her progress. I have the hand grip and sit and reach norm charts below. Case study exercise testing initial results. Her aerobic 6-minute walk results were 350 meters walked, an initial heart rate of 100 beats per minute, a final heart rate of 127 beats per minute. Her initial rate of perceived exertion was 1. Halfway through it was 7, and then 1 minute after the test it was 4. Her resistance hand grip isometric strength test scores were 22, 20, and 25 kilograms. Using her best score of 25 kilograms, she falls just below the 50th percentile of women her age, and roughly 35th percentile for initial resistance exercise testing. For the flexibility sit and reach test, she received the scores of 12, 14, and 16 inches. 16 inches falls into the average category for women her age. For exercise prescription for cardiovascular, I'll do cardiovascular activities 3 to 5 days a week for 30 to 60 minutes at 50 to 70% of her heart rate reserve and tracking her RPEs between 4 and 7. I've listed below her 50% heart rate reserve was 133, her 60% is 139, and her 70% is 146. Week 1, I will be following the lower side of these guidelines and only increasing her cardiovascular activity by 5 to 10 minutes every week for the first 5 weeks, and no more than that. Exercises will alternate between outdoor walks at a moderate pace and then a recumbent bike as well. Her heart rate will be measured before, in the middle, and after exercise, and her rate of perceived exertion will continue to be monitored before, in the middle, and after. The 6-minute walk test will be retested every 3 weeks, and this will be a great time for her to be able to see analytical data, to see her progress and how much she has done. This is a really great motivation for the client to observe the heart rate and the RPE as well as the meters traveled. For prescription resistance, her resistance training is 2 to 3 days a week for 30 to 60 minutes a day using body weight and light band exercises. Exercises alternate between upper body and lower body days. She'll do a routine hand grip test every 2 weeks to measure how far she's gone. Like I mentioned before, this is a really great motivation to see the analytical data of how many more kilograms she's doing on the hand grip. For her upper body resistance day, she'll be doing light band rows, light band shoulder extensions, body weight table assisted push-ups, 5-pound farmer carries, and 5-pound basket carries. For her lower body resistance day, she'll be doing body weight squats, body weight lunges, 1-pound ankle weight hip adduction, abduction, hip extension and flexion, and then 1-pound ankle weight marches, as well as continuing with the farmer and basket carries. Case study exercise prescription flexibility. Flexibility will be done before and after every cardiovascular and/or resistance training. I will remeasure the sit and reach flexibility assessment every 2 weeks to track the progress. 10 minutes of dynamic stretching before the exercise will consist of leg swings, arm swings, hip circles, step up and over stretches, and Frankenstein walks. 10 minutes of static stretching following exercise will consist of the single kneaded chest stretch, piriformis stretch, hamstring stretch, barber stretch, posterior capsule stretch, and then a shoulder internal rotation stretch with a strap. These will be done for 10 times for 10 seconds. Modifications and precautions for exercise prescription with MS. The use of handrails and belts to decrease a fall risk. Taking breaks after every exercise due to increased fatigue levels. Increased water intake, and then also watching the room temperature to maintain her body temp. Also, using a pool when available to help cool body temperature is a great option because it decreases pressure on joints and also helps with fatigue and balance problems. We'll start slow and reevaluate after each exercise. Investing in cool packs and fans is also a great way to help manage body temp. To conclude, multiple sclerosis is an autoimmune disease that destroys myelin sheaths on nerves. Exercise is shown to decrease disability and atrophy with those with MS. Medications, like I mentioned, interferon beta medications, can be an option for calming symptoms. Treatment consists of physical therapy, activity, and exercise. There is unfortunately still no cure for multiple sclerosis. Exercise is shown to decrease spasms and flare-ups in MS, and cardiovascular resistance and flexibility training has been shown to benefit those that have MS. And then here are my references that I used. Thank you so much.